Hello everyone, welcome to join our COXO public webinar again. This is Chess. We are glad to invite Dr. Ahmed from Iraq to talk about this course. And by the way, this COXO public webinar, we prepare a certificate for dentists who join our course. Now, the first step, follow and like the COXO page. The second step, and leave your comment or question below the live video. At the end of the live, we will share the phone link to the comment below the live video. And please open the link and fill the form and submit to apply for the certificate. About the 3 day all done, in Friday you will receive PDF formal certificate in your email. And please note the form application can be filled only one time and will be available for only 5 hours after the lecture. 5 hours later, the application channel will be closed. After that time, we will not accept any application. So please on the form as soon as possible after the webinar. The form cannot be modified. Please make sure the information you need are correct. And now we invite our exclusive Iraq distributor, Shiny Dan, to introduce their company. Okay, welcome to Shiny Dan. Hello.
Hello, Chelsea. How are you?
How are you?
Hello.
I'm fine. Okay,
Hello.
please share the Shiny Dan to us.
Okay. Uh, Today we are talking about Shindent company profile, which is a huge dental company all over the Iraq. Shiny Dent Company is established at 17th December 2030. At 2030, we started with main office, which is located in Erbil, Kurdistan, Iraq. From 2030 till now, Shine Dents try to make a dentistry and dental supply as shiny as possible. Shiny Dent imports and distributes dental materials, equipments, dental instruments, dental chairs, dental implants from many international companies like Madespa, Deline, Kigon, Ufit. Among them is COXO. Schengen is an exclusive agent in all over the Iraq. We provide COXO products in all of our branches as well as all of the sub-distributors in Baghdad, Erbil, Slimani, Duhok, Kirkuk, Mosul, Babel, all over the Iraq. We also have a free delivery from the Global Dent office in Baghdad to all over the Iraq. You can order your necessaries in this office. Let's talk about some products and COXO products in our company. We distribute very high quality, high speed handpiece in our company, which is available in many colors with or without lid. About the endodontic, we distribute endomotors and apex locators in many models and many types, which facilitate your root canal treatment and make your procedure easy and precise. We also have a COXO Cephal Mini, which is a hot obturation system. This is for the root canal treatment procedures. About the for the implantologists, we have an implant machine, which is a COXO implant machine, which is available in two models. And these two models are available in most dental clinics in all over the Iraq. And the doctors are very comfortable with the use with this machine. We also have air abrasion system with spray from COXO, which is used for the polishing and for the sandblasting. And as you see, this case is done by this abrasion. It will give you a nice result. You can try to use it. And also you have Ultra Smart for endo activation as ultrasonic activator. And we have a C-blade from COXO for gata cutting. And for the orthodontist, we have a Swift Light Cure, which is works in a 3 mode. You can use it for the filling and you can use it for the orthodontic treatment. We also have a electrical motor. We distribute it to all over the Iraq. As you see, we have these two types. Nowadays, we have a new generation of this electrical motor, which is works as a electrical motor and indo motor. Consists of two contra-angle heads. For these two purposes, you can use it. About the light cures, we have a many types and many shapes, many colors from COXO company, and you can order it. We have a new generation of curing light. The huge advantage of this light is the curing depth, which is 8 millimeters deep, and has a light body diameter, which is only 13 millimeters. And you can use it as a light cure and as a caries detector. About the dental lights, we have many models and many shapes in a different prices and a good quality. Also, in Shine Dent Company, we have a COXO dental microscope, which has a 5 gears magnification and big range zoom objective. In Shiny Dent Company has its own servicing and maintenance team for all COXO products. And this gives our customers a real guarantee and after-sales service for all equipments. And this is a short description and conclusion about Shiny Dent and about COXO products in our clinic. Thank you for your listening. Enjoy your webinar.
Okay, thank you, Charlie. Then, if Iraq dentists are interested in our product, please contact our distributor, Shiny Dent. So now it's our time for our webinar today.
Thank you, Jesse.
Thank
Enjoy
you.
your webinar.
Hello, Dr. Ahmed.
Hello, Jason.
Hello.
Hello.
Thank you, Dr. Ahmed. Take time to share your good experience for our dentist friend. So now it's time for Dr. Ahmed to begin this time course.
Okay, let's begin. Hello, everybody. First, I'll thank COXO Company for arrange such a series of webinar about the endodontics. Our webinar today, the most common obturation technique in modern endodontics. So at first, I'm Dr. Ahmed Hani, dentist specialized in microscopic endodontics, CEO and founder and owner of Breha Specialized Dental Clinics, Basra, Iraq. Graduated from University of Basra, College of Dentistry in Iraq. I'm an official speaker and co-opinion leader on Eradika in Iraq, and official speaker and co-opinion leader of Medicalas Company in Iraq, and senior at Basra Dental College Endodontic Department. Today, we will talk about the types of obturating technique that will should choose in each cases. What I choose in each case to do an obturation. We have many types of obturation technique, just like one vertical convection, recently single cone with BC sealer, squirting technique, bio-obturation with calcium silicate based materials, or thermofold carrier based obturation. So let's see what I should choose. At first, I will talk 2 slides about before we reach the steps of obturation. The long-term success of endodontic treatment basically depends on educate a 3D cleaning of endodontic spaces after canal shaping. then followed by a 3D obturation of complex root canal. So the endodontic space composed of area that the files, okay, or shaping cannot reach it, such as isthmuses, laterals, siblet, ramification, deltas, dentinal tubules. So in such cases, we need to clean such spaces that I mentioned before: laterals, loops, ramification, delta. How I clean these spaces? Sure, by biochemical cleaning, by irrigation and activation many times to get a clean area for this spaces. So we in endodontics we have accessible canal walls and inaccessible canal walls or area. So we should clean all of these area to get a perfect 3D cleaning. So after that we do a perfect 3D obturation. When we come to obturation, there are different techniques, mainly warm and cold techniques. In literature, there are no significant difference regarding whether the warm obturation is better than cold, but it is illogical and well demonstrated that a warm filling can fill the endodontic spaces in a 3D dimensional way in comparison with a cold one. So only canals shaped in a correct manner can be filled with Gutenberg tri-dimensionally. So we should clean very well our spaces or our root canal system, then I should fill it in a three-dimensional way. So how to that? How to clean our spaces by, as I mentioned before, by irrigation, shaping by files, night-eye files, then irrigation, then activation by ultrasonic devices such as UltraSmart from COXO. It's a very smart device and efficient. Maybe it's used also for locating of hidden canals. It has 3 tips: activation of irrigant, and also I can use it for removal of dentine and a retrieval of fracture and settlement. So by activation with this smart device, ultrasonic, we can get such siblet opened and clean and filled, such laterals, such this C-shape isthmuses, huge isthmuses in lower second molar. So how to clean that area? Also, as I mentioned before, by irrigation and activation ultrasonically. Okay, many times with activate the sodium hypochlorite, EDTA. So then dry it and fill it tridimensionally by the appropriate technique. Also, how to fill such siblet, how to open, how to clean it, as I mentioned before, by ultrasonic cleaning, not by file, such area not reached by file. 35% of canal walls not touched by file during rotary and end instrument. So how to clean and fill such area, internal resorption and whatever, laterals, by ultrasonic activation of the irrigant solution. So also here there's a tree apically, tree of laterals, loops. How to clean it? Also by ultrasonic activation of irrigant solution, mainly sodium hypochlorite, ethylene diamine, tetracitic acid, EDTA. Okay, let's classify obturative techniques. Mainly I will simplify this. I classify it, before I classify it, I will mention this. The wealth option available in obturation, challenges to which technique to adopt and what ramification, how I choose the appropriate technique for my case. Okay, now we'll know how I choose. It's depending on the anatomy, it's depending on each case. At the first, obturation technique simply can be divided into these classes. First one, the master cone based techniques. It's warm and cold techniques. Number 2, squared method or squared techniques. It is non-master cone based technique, carrier based technique, Fourth, bio-obturation, obturation by biomaterial, calcium silicate base material. So let's discuss it one by one. First one, master con base technique, which involve many techniques. First one, cold lateral condensation, system B, vertical compaction, one vertical compaction, single cone methods, continuous wave of compaction technique, lateral condensation followed by warm compaction, recently single cone with VC sealer. All these techniques, we should have a dry canal and a true apical take back, not coronal take back, a true apical take back until I go for such techniques. Okay, let's briefly talk about the cold lateral condensation. It's a time-honored method of obturation that simply depends on a sealers pushed by a cold cones to reach an area such as laterals or ramifications. So it's these spaces filled mainly by a sealers, not by a guttapercha, and sealers may be resolved, so there's a problem in cold lateral condensation. So core obturation not reach to these ramifications or isthmuses. Why? Because it's a cold core, not a hot, cold or molten cataperca to reach such area. So we should shifting to hot techniques or hot way, molten cataperca, to get a 3D obturation and fill such spaces. Which one is the system B? It's a relay on source of heat of obturation, simply in concept and validated in literature and dental operating microscope. It's possible to perform a down back with a pin of system B and backfill with a gun with a precision. So vertical compaction is a variation of system B. With vertical compaction, it's a precursor of the two techniques. Simply, there's a main one different. In system B, the cone is compacted in one down back motion, one wave of compaction, one attack from the coronal to the last 3 to 5 millimeters. In vertical compaction, there are multiple down backs alternating heat and pressure. So this is an excellent device from COXO, which is a CFOL. It's a gun of backfilling, and this is a pin of down back technique. So it's a great one. So let's see how to do a one vertical compaction. This is a case of a perforation, and I would make a one vertical compaction below the perforation level. So how to control it? It needs some experience, skills. After removal of guttapercha, which is in perforation area, let's reach. Now it's okay, everything good. This is the perforation. This is the guttapercha main canal. Okay, I will obturate activation. I will obturate the mesial one by one vertical compaction, which is near a perforation. Below, this is the main canal. This is the perforation. So I will obturate. This is a sealers. I use here I'm used MTA premix sealers. This is the cone and this is the pin. I will do a down back to 3 or 5 millimeters from the working length, our working length. Then back it by metal blagger. Pack it very well. This is an easy example of when vertical compaction techniques. Then I will put an MTA over it to seal the obturation area. Then after that I will do a backfill technique, injecting a molten cataperca over it. So here I'm using such a device system B, such as a CFOL, which is a pin and a gun, down back and backfilling. Now I will put MTA Pack it very well. This is a piece of MTA, black. Also pack it. After finish it, then I pack full of Gutenberg using gun pack filling system. Then I mold it the tooth. So this is the down back, and this is the final. We should have a great tag back, a real apical tag back, to prevent Gutenberg from extrusion. So simply our own vertical compaction techniques. We check after we get a dry canal. We check our cones tag back if it is a real apical tag back. Then we put a sealers. Here use a zinc oxide digital sealers or aneurysm based sealers. Okay. Then by a pin, okay, we cut at the orifice level. Then down back 3 to 5 millimeters from the working length and pack it by a metal plugger. Then we can pack full the remaining spaces by a backfill device which inject a molten Gutenberg. So the advantage of this technique, it's full 3D dimensionally, irregularities, accessory canal, better filled, excellent seal of the canal laterally and apically. What is the disadvantage? It is a time consuming, risk of vertical fracture, less control, overfilling with Gutenberg. This is a disadvantage mentioned in literature, but we can manage it by experience and the skills. The wound vertical compaction is considered as a gold standard techniques in obturation. So together we got with Gutenberg, the most commonly used sealers, those based on zinc oxide as well as eugenol, zinc oxide sealers, eugenol, and resin based sealers. This is in almost technique used. In recent years, a new generation of sealers, the bioactive sealers, which is less toxic with a great healing capacity, have been released on the market. The BioSeal, however, this BioSeal have two disadvantages. The first one they must be used with the cold single cone technique because they cannot be heated. When touched to the heat, it will be hardened. Therefore, they are not able to obturate in the endodontic space in 3D dimensionally. So, the second disadvantage, their consistency. Their consistency after hardening, they harden a great deal, and in case of retreatment, the problem become more complicated. So, recently, a new 3D obturation technique was discovered or described, which is a hot modified technique first described by Prof. Alfredo Lundillo on 15 July 2018, including use of opio sealers with a one vertical compaction by doing modification in temperature of a heat carrier, our pin, to 130 to 150 Celsius instead of the average 200 to 250 Celsius. Just minimize the temperature which is in touch with a biosealer to make a control in this material to prevent its setting rapidly. So let's see a case of a head to modify technique. It's a case of file fracture retrieval, and I will do hot modified techniques in distal canals. So first I will manage these files. Here I'm using the ultrasonic devices, which is for activation or elegant activation I use it to remove a dentin from internal canal wall. This is one. This is an ultrasonic device for activation, just like UltraSmart from COXO. So after we remove an internal touch, ultrasonic touch on internal canal wall, make a fragment loose, then we will catch it after checking its mobility by DG16. Now it's ready to get it out, take it out by extracting technique. Here I'm using loop techniques. I insert my loop, grasp it, take it out. After I take it out, I will clean all the canals three-dimensionally and then obturate it. So let's talk about hot modified techniques, doing irrigation activation, ultrasonic activation, just like UltraSmart from COXO device. Now it's ready for obturation. Now let's do the hot modified technique distally. I'm inject a bioceramic sealers, calcium silicate based sealers. This is our cone. After I check my take back, true apical take back, so down back, then I will backfill molten catapulta mixed with bioceramics, biocompatible sealers. As I mentioned before, we are just change the temperature of our pen device to 130 to 150 Celsius to get a control of a properties of biosealers to prevent it from get hardened before it folds all the anatomies. So this is the final. Everything is okay. So we have many other techniques: single cone, continuous wave compaction technique, lateral condensation, recently single cone with PC sealers. So I will show the most common one. It is, I have a video about single cone with BC sealer. So let's see it. It's a retreatment also of tooth number 37, lower second molar, badly cleaned and badly obturated. Also I used ultrasonic cordless device, just like UltraSmart from COXO, to loosen the fragment of separated instrument and then catch it by micro tweezer here. Then fold the canals with a canal with a single cone and calcium silicate based sealers, which is recently launched into the market in the last 3 to 4 years. These techniques, depending on the properties of the bioceramic sealers, calcium silicate based sealers, which alkaline pH, bactericidal, expand when set, zero shrinkage. All these properties get a benefit to do dimensional using calcium silicate materials with just a single cone. We cannot use this technique with a resin based sealers or a zinc oxide based sealers, or zinc oxide will resorb and have a shrinkage when set, so leave a spaces. But calcium silicate based sealer, no, it expand when set, zero shrinkage, bactericidal alkaline pH. Calcium silicate based material is just a filling material, not just a sealer. So after Gutenberg removal, let's go. This is ultrasonic, this is activation. Using device like UltraSmart from COXO. This is our operating instrument. So let's obturate. This is a bioceramic. Inject it in the coronal third and passively upward motion to the orifice level. Then agitate the sealer to distribute it inside the canal. Then cut it by our gun, just like a C-full from COXO gun. Pin, heated plugger pin. Cut it, just like that, and pack it at the orifice level with a metal plugger. That's it. Then we will remove the fragment. I catch it by micro tweezer after loosening using UltraSmart ultrasonic device. So this canal, I obturate it also, cones with bioceramics. So this is the final. Everything is okay. Done. So we will talk about the second group. I mentioned the first group, which is a master cone based technique, which is mainly used or is most commonly used. It's a warm vertical compaction technique, a single cone with VC sealer, and hot modified technique. This is the most commonly used recently. So now let's talk about the non-master cone based techniques, which is a square technique, non-master cone based. In that obturation, material is extruded from a cartilage tip of our gun, just like a C-fold from COXO, to the canal, backfilled in a segment or in a square. It's preferred to get in a segment, just like 2 millimeters for each segment, with heated obturation material, molten Gutenberg, injected, and compact it with a plastic or metal plugger. In experienced hand and ideal canal preparation and under dental operating microscope, this technique can be used safely and efficiently. The first article about this technique is published in 1977 by Ye and others, a three-dimensional obturation of root canal system using injected molded thermoplasticized dental Gutenberg. Also, there's in this article, the colleague explained the technique and the armamentarium employed in vitro. After that, 1981, Marlin published an in vivo study in which this technique was employed with a success. So, also John Stripko published an article about this technique using modern armamentarium. It's an efficient technique under skilled hands. It's do a great work. So, an indication of the square technique, first one, in vital cases when a patency not obtained. One of the principles of RCT at a get patency by K file number 10. So when I try to get a patency and I cannot get it, so I do a shaping to that point when the file reached, and do shaping to that point and irrigation and activation very well, but ultrasonically. Then I will do, or I will go for squirting technique. Second case, without a lesion, because a lesions may cause a resorbed apex, so maybe the molten Gutenberg can get out, extruded out of the root canal system, and this is a problem. Third one, curved and thin canals. Gutenberg is really soft, and in case of curved canals, it's a valid alternative for thermofill. Okay, blocked canals or when we couldn't reach the working length. In such cases depend on irrigation, as I mentioned before, and activation more and more than doing squirting technique. 5. Confluent canals. The main canal obturated by thermophil or any other 3D obturation technique, and then the confluent canal do it with a squirting technique. It's just backfill the molten cataberca and back it by metal or plastic plugin. 6.1 apical bifurcation. Also, I can do it. We can do it, or even a ledge sometimes. So what is the contraindication of squirting technique? In case of a lesion, as I mentioned before, there is a wide or resort apex, increased risk of overfilling, so it's a contraindicated in such a case when a foramen size or diameter bigger than 50. So now we will go for other techniques. If there is a parallel or inverse taper, I mean diverge apex, here MTA is the best choice in such cases. So this is the main contraindicated for such technique. Just like this case, retreatment of lower second molar. Distally, I cannot get the full working length. There is remaining at least 1.5 and to 2 millimeters away from the root apex, so I cannot get a patency. I depend on irrigation and activation and do shaping that point when the file is reached. Shaping, irrigation, activation, and go for squirting technique, and then I will fold such great anatomy, which is a collections of laterals and ramifications filled with a molten cataberca, not just by a cedar, it's by molten cataberca. So let's see a video describe how to do squirting technique. Also, it is a case of retrieval fracture instrument. It is my lovely cases. So after we remove this separated instrument using ultrasonic, also just to correct the axis. Now it's ready to go on site. Irrigate by sodium hypochlorite and do activation to clean that spaces before I go to retrieve of separated instrument. This is an ultrasonic activation, just like ultrasmart from COXO. This is the fragment, separated files. So let's touch ultrasonically on an inner wall to get a space all around this fragment, and then touch it by extracting tool to get it out. This is ultrasonic touch on inner wall. Now it's ready. Let's check it. Let's take it out. I get it out. So now time for irrigation, activation, shaping, irrigation, activation ultrasonically. Then we go for obturation. I will do a squirting technique distally because I don't obtain a patency by K file 10. So I just, this is mesially single cone with PC sealers, as I mentioned before. Distally, I don't get a patency by K file number 10, so I just shaped to that points when the files reached, where the files reach, and shape it well and irrigate it well and activate it ultrasonically more and more and more to get a clean and smooth walls. Then I will go for a squirting technique distally, and mesially I go for single cone with bioceramics. This is a squirting technique. I inject a bioceramic sealers, molten göteborg, a segment, then back it by a metal blagger to the length where the file is reached. Pack it gently so the molten göteborg will fill all the spaces if I do a perfect cleaning and shaping. Another segment till I reach the orifice. Molten göteborg from our gun, just like seafoam from COXO. And this is done. Packing it. It's finished. Let's see the x-rays distally for squirting technique. It's perfect. Sealing all the canals, and this is a split apically sealed by a molten göteborg perfectly from apical to coronal part using squirting technique. So now we talk about the third one, which is a carrier-based technique. A carrier-based technique is I use a plastic carrier coated with a sleeve of cataberca, alpha type of cataberca. Okay, put it in a special oven and turn it on and place it to the length in the canal after get a dry canal and after we put our sealers. In theory, the carrier is centered in the canal and the cataberca circumferentially present around the carrier. In such cases, retreatment is a challenging cases. Also, it's depending whether the göteborg circumferentially surrounded the carrier or what is the carrier wedged inside the canal alone. So after finish the obturation by a carrier based, we should cut a plastic carrier by a bear with the orifice level. This is a thermofoil. This is a plastic core surrounded or coated by a sleeve of alpha type cataberca, indicated especially in severely S-shaped canal, double curved canal. Here a case I'm used thermofoil, carrier based obturation, lower first molar, lesions. So after remove the göteborg, check the length. I put a resin based sealer. I go for my carriers, a thermofoil, a carrier based obturation for both distally 2 canals and mesially, which is a confluent canals. Okay, but there is a laterals here filled with a molten göteborg, which is by a thermofoil or a carrier based obturation. And this is the immediate post off of this case, and this is before, and this is a 1 year follow-up. It's complete healing. So this is another case which is indicated a carrier based obturation, a severely curved S-shaped lower second molar, especially a mesial root, and a curved distal root also. So for mesials I go for a carrier based obturation because it's a severe curved S-shape. Distals I go for single cone with bioceramics. So you will check your case and you will go for appropriate technique for obturation is depending on the case. This is the final, completely filled 3D dimensionally, and this is the soft core. Okay, let's see how to do an obturation by thermophil or carrier-based obturation. There's two techniques recently. The first one I will show you. It's recently described. So after dry a canal with a paper point, I will inject a pyroceramic sealers, calcium silicate base sealer. We can use it, yes, with a thermophil. Then inject it just in coronal part, slightly. Then I will distribute it by a plastic obliger all around the canals, just by push and pull motion, just to distribute the sealers on the canal walls. And this time I put my carrier-based obturation cones in its special oven. When there's an alarm, that just like beep, so it's ready. I get it from the oven and insert it within 10 seconds. Within 10 seconds inside the canals. I have just 2 seconds until the cone is cold, and the göteborg it's became cold one, not hot or molten. So after 10 seconds everything is okay. Now I cut this plastic carrier within the orifice level. Now I fill the canals, all the canals. This is a view, a carrier in the center, circumferentially alpha type of göteborg. All canals was filled by thermophil and calcium silicate base sealers. This is recently described using a calcium silicate base sealer. The most common use with this type of göteborg or this type of obturation technique, resin base sealer. I'm coating the canal walls counterclockwise with a resin base extra thin layer of sealers, resin based sealers. I get a new paper point to dry the canal and get out the excess of sealers. I want an extra thin layer of sealers. Then when it's ready, I take it from its oven and insert it. Let's see, the laterals is filled by thermophil göteborg, molten göteborg from carrier-based obturation. Now after 10 seconds everything is okay, ready to cut it. Okay. Let's talk about the last one, which is a pyro obturation, which is use a calcium silicate base. In some cases, when a foramen diameter larger than 50 or 60, it's better to use a calcium silicate base material, MTA, biodentine, PC putty, just like for obturation to get excellent apical seal when göteborg cannot obtain it because of a large diameter of the foramen. In göteborg I cannot get a real and a perfect apical seal, so I go for bioobturation by calcium silicate based materials. Some endodontists, even in normal cases, use a bioobturation to get all the benefit of this material, such as strength to the structure as its bond with it chemically and bactericidal effect, expand when set, alkaline pH, and other features of this materials. So let's see how to obturate by this technique. When we have an foramen diameter larger than 50 or 60, so go for bioobturation to get a perfect apical seal. This is the second premolar. Ovoid canals. Check the foramen diameter is larger more than 50, so I go for bioobturation. Here I'm use just a few amount of calcium silicate base sealer. Then I will put a calcium silicate putty, PC putty. Then I will pack it by brush bond or a metal blagger gently. Now the PC putty will push the pyroceramic sealers to fill all spaces. Also the PC putty fill all the spaces. Then I push it gently by files smaller than the last file you are used, in this case, and file smaller than your master apical cone files, master apical file files. Then pack it also by a metal bagger gently. Again, a piece of sealers between two increments, a little bit bioceramic sealers, then another piece of bioceramic putty, packed by brush point gently. After that, you can use a fast set bioceramics putty till you can finish the case in a single visit and secure the bioceramic putty coronally by any flowable composite or pulpful composite or fiber reinforced composite. So this the final touch by a paper point, completely filled. You can see the perfect seal coronally, and then we will see in X-ray the perfect seal apically. Such like this case or this type of canals is difficult to fill a 3D dimensional way in a 3D dimensional way by using Guttaberka. So difficult. For arm diameter larger than 50, 60, go for obturations. Now it's set, completely set. And same visit, I'm using a fast set bioceramic putty. So etching and bonding, you can do it in the same visit after final set of the material, because I'm using fast set in this case. Secure it with any type of bulk full composite. Then cure it. This type of obturation also strengthens the tooth, as it's act as a monoblock within the root. It's as bonded chemically, bond to the dentinal wall clinically. In such cases, we should change the final irrigation protocol to get all benefit of this material, to get it bonded to the dentin. So this is the final after putting a fiber reinforced composite. Let's see the X-ray. This is a perfect apical seal. Also there is a split filled with a bioceramic putty, perfect apical seal. This is a split filled by bioceramic putty, which is missing preoperatively. So now I finished my presentation. Thank you all. If there is a questions, I'm ready.
Okay, thank you, Dr. Arman. So wonderful speech. I think this time the dentist friend can really get more skill again. And Dr. Arman, please see the comment and answer the question.
Okay, let's see. In which case we can use zinc oxide regional.
And Dr. Arman, please see the comment and answer the question.
There is a question from Mustafa Al-Atabi, and its question is, in which case we can use zinc oxide regional paste, and what will happen later when resorbed. So when we use zinc oxide regional sealers and do an obturation, a cold obturations, not a warm obturation, there is a risk of resorption for that sealer, because in cold techniques we depend only to fill such spaces like laterals, ramification split on a sealers, because the main core is a cold. So when these sealers resolve, there is a gap, there is a host for bacteria, for biofilm, there is a chance of failure. But when we using coccidigenol with a warm vertical compaction technique, sometimes, or sorry, it's okay in warm vertical compaction because these spaces, such as sepalate, ramification, laterals, isthmuses, will filled with a molten guttapercha. So even if there is a resorption in these sealers, the remaining molten guttapercha filled that spaces. Okay, let's see other question. Significance of apical buff created by extrusion of sealer. It is better to avoid any extrusion of sealer in the periapical region. Yes, yes, there is no any significance of apical buff created by extrusion of sealers. No significance for that. It's better to keep a root canal filling material inside root canal system. This is done by when we get a great and a true apical tag back. So you get a control your 3D dimensional obturation techniques and prevent extrusion of guttapercha or sealers. But also this topics about extrusion of sealers is uncontrollable, especially in chronic cases when there's a lesions, there's have a white apex or absorbed apex. We cannot prevent 100% extrusion of that sealer, but we can minimize this by get a true apical takeback. Okay, it's better to avoid extrusion of sealer in the periapical. Yes, it's better to avoid it. What is the effect of unfilled lateral canals on the failure of endodontic treatment, and what is the best technique to treat? The effect of unfilled lateral canals, sure, it will be filled in the future. There's a space, there's a gap, filled, there's a host of biofilms, of bacteria, filled with a biofilms. This is a cause of, which cause in the future failure, which is hosted in lateral canals. So we should clean the laterals by ultrasonic activations and irrigation more and more, then fill it with a warm guttapercha or any techniques can get by it a 3D dimensional obturation, such as single cone with BC sealer, warm vertical compaction, continuous wave of compactions, and thermofoil and others. So this is the questions. Any other questions? You see it? I answer all the questions. If there's any other questions, can you hear me?
Okay, I can hear you. Thank you, Dr. Arman.
Thank you.
And you can see the screen. Please check the question. Okay, I can hear you. Thank you, Dr. Arman. And you can see the screen. Please check the question.
Yes, I see. I see the questions in the comments. I think I answered it all. If there is another question, I cannot see it. Can you read it, please?
Okay, well, thank you. And Dr. Arman, have you seen the best question? Please choose the best question.
Okay, the best question and the important question that is done by. This question is how we prevent the sealer extrusion, and what is the importance and significance of the sealer extrusion,
Okay.
how can we prevent it? You get it?
Okay, congratulations, the lucky person, and get our SC profile, she says. Will continue soon. And every time the webinar, we will have a lucky gift for the dentist who join our course. So this time the gift is 3 set SC Pro. We will choose it tomorrow. And thank you to Dr. Arman this time. Whole future you will make another new speed again soon. I have added a link for the certificate on the comments, so if the dentist friend who joined this course needs certificate, please fill this form information. Then we will supply for you soon. And this link need to fill within 5 hours after the course. Thank you to join this time COXO free public webinar. Hope to see you all again next week. Have a nice day. Goodbye, everyone.
Goodbye. Bye bye.